buccal plate. So this lesion is fairly aggressive. It's coming straight out at me. I can't see that. There's nothing wrong with number 14. So I'm very clear here in my diagnosis. I know exactly where the floor of the sinus is, and coincidentally, I've got some fluid buildup in the stridarian membrane, indicating an inflammatory process that just happens to be right above tooth number 13. So I want a good picture, a good image. Image quality, it's paramount. I want a small focal spot. I want to know the number and size of voxels in a machine. I want to know the number of slices I need. Is 360 too many, not enough? How many is 512? What's the advantage of taking 1024? Does it do a 180-degree rotation or 360? These are the kinds of questions I find that doctors don't ask. They basically ask one question: how much does it cost? And so as we do some investigation, we find out that some of the answers to these questions make a difference in our image quality. If you look at the image on the left, what you're going to see is very sharp, crisp, clear images. If you look at the image on the right, you're going to see a little more fuzzy effect. This comes from a larger focal spot. If you have fewer slices, the image is not as crisp. If you have a larger focal spot, the image is not as crisp. These things make a difference when we're trying to diagnose things such as, oh, let's take an MB2 canal. So I've been seeing some emergency patients, and this week I saw this young man who came in for an emergency for tooth number 14. Now, I went back a year ago when I saw this young man for the first time to take out his third molars, and I looked at the date, 4/22 of 19, and I looked at the anatomy of his teeth. Here's the mesiobuccal root of number 14. Here is the distobuccal root of number 14. I want you to pay particular attention to the anatomy of the bone to the root. The root's very close to the buccal plate, but still the contour of the bone to the root. This young man called me now a year later and said, Dr. Julian, I'm having pain on number 14 and I need some help. So I took a second cone beam because I went back and looked at this and saw nothing wrong other than he had a deep filling in it. And now I take the second cone beam and I come across and I look at the mesiobuccal root and I don't see a lot of change. I look at the distobuccal root and I see a significant change in the bony contour around that root. So something has caused an alteration in the bone here. It could be orthodontically, some aggressive orthodontist moved the tooth out, but he hasn't been in ortho. Or it could be that the bone is simply eroding away from the canal. And this turns out that the tooth had abscessed and there was an active infection out here eroding the bone away. Now, here we're going to contemplate treatment, and our treatment would be probably endodontic therapy. So if I'm going to do endodontic therapy, I want to know how many canals am I going to be treating. And this is an axial view that shows me a palatal canal, a distobuccal canal, a mesiobuccal canal, and a mesiobuccal 2 canal. So I have 4 canals in this tooth. Well, sometimes the MB2 joins into the MB1. So I come now to a different view and I look over here and I see 2 distinct canals. So I know I'm going to have to instrument 2 canals, but do they ever join? This root is curved, so I tilt my plane, change my perspective, and now I go to the tip of the root and I find still 2 canals. So I will be filling these 2 canals independently of each other. I've located them, found them, and I understand that they will be separate. This is the kind of information that there's just no Pan-Rx, there's no 2D film that's going to give this to you. So if you do a molar root canal, you want to know all of this information. Now, what I find interesting, I'm going to go back up for a second, is if I go back over here, the bicuspid, number 13, has 3 canals. So I have the palatal, and the buccal is divided into mesiobuccal and distobuccal. So any tooth that I may have to do an endo on, I can look at the number, the size, the shape, and the configuration of the canals prior to doing endodontics. I can even measure length of the tooth to determine if my apex locator is going to be working correctly. Because if I get a number like 20 and my apex locator says 16, then I know the apex locator is giving me a false reading. But if it's, I say 20 here and the apex locator says 19.5, 25, 21.5 or something close, then I know it's reading correctly. Sorry, I had these slides ready to go. Okay. So every time we come up with a clinical scenario, every patient, every single day, there's 2 questions. And the first question is, what's the correct diagnosis? Not what's the best guess, what's the best reasonable conclusion based on my experience, based on my prejudice, where I was trained, what's going on in my mind, but what is the correct diagnosis? Based on that diagnosis, I can now engage the patient. And once the patient's engaged and he can see his diagnosis, he can see what's wrong, then what's the most appropriate treatment based on his diagnosis? Now, the treatment can change a lot. We can get people disagreeing on treatments, and I'm not going to worry about disagreeing on treatments, but the diagnosis must be correct. So when you see a case like this, again, tooth number 2 is our tooth of concern. The patient's having absolutely no symptoms. He comes in for a routine cleaning. We take a cone beam every 3 to 5 years, much as we would a Panorex. And this patient complains of no pain, no sensitivity in tooth number 2, or 3, or 4. But when I took a cone beam on this patient, what I saw was tooth number 2 has an extremely large lesion, and that lesion indicates the need for endodontics or extraction therapy, but the patient doesn't understand it unless he sees the evidence. So we explain what good healthy bone looks like, and we show him an example, and then we show him a big dark area around that tooth. So here's a patient that he went to another dentist, and the dentist made a recommendation based on his 2D Panorex. Tooth number 30, 31, and 32 are present. And the dentist recommended an endodontic procedure on 30, an endo procedure on 31, and extracting number 32. So we sat down with the patient. We evaluated all 3 of the teeth. We looked at things from the view of what is it that you might need. And we drew in the canal so he could see where his nerve is. We walked through the tooth, literally slice by slice, walked through the tooth to see that the cavity that we can see here is extremely large, and this enters into the nerve. The cavity that we have here and the fracture does not enter into the nerve. Well, if that doesn't enter into the nerve, why would we consider doing a root canal on this tooth? So tooth number 30, we changed the treatment plan from an endo to a crown, just to build up in a crown. Then we went back to number 31. Now we looked at the depth in toward the tooth, and then also the depth vertically down along the distal root. Then we also looked at the bone level on the distal root. The patient said, is that going to cause me to have trouble in the future? And I said, well, I can't predict the future, but I'm telling you that's an indication of a potential further problem, yes. And losing the bone back here, there is no guarantee we can ever grow it back. So we agreed that number 32 should come out. We disagreed on number 30. We decided to restore it and keep it. 31 was the patient's choice, and the patient chose to extract the tooth. he has the option of placing an implant at a later time. So the whole treatment plan is based on accuracy. How accurate were we in describing what was going on for this patient? If we're going to take out 32, the next thing we want to know is, well, our treatment, is it something I want to do or something I wish to refer out? So we looked at the position of the roots, we drew in the canal, and now we're looking at a cross-sectional view to see how close the root of that number 32 comes to the canal. And this is going to require some experience in getting the tooth out without causing a paresthesia. And it also, discussing paresthesia with the patient is the proper thing to do in this case. So there's no question as to location, accuracy, determination of what types of issues we're going to have to deal with in our treatment. Do we want to refer or do we want to treat this ourselves? So here we've got a patient, and I've underlined the date of the cone beam, which was July 17th of 2018. On July, we took a cone beam, and I pointed out to the patient that she had what we call a small lesion around the root of tooth number 4. And I showed it to her from 2 views. She said, but doctor, I don't have any problem with that tooth. And I said, I know you don't, it doesn't hurt. But many things we find don't hurt. And then when they do hurt, the patient thinks they have an emergency, when in fact it's been growing for a long time. Well, as persuasive as I am, she didn't listen to me. And she decided to go on about her business. In November of 2019, so about 1 year and 4 months later, she calls me up and she says, you know, I'm having some sensitivity and it's on my upper right side. I went back and looked at the notes. I went back and looked at what I had, and I said, well, you know, it wouldn't hurt to go ahead and take another cone beam to find out if it's grown any. Now, let's go back to the radiation discussion for a second. I said it takes me 76 microsieverts to take one of these cone beams. It takes 180 to do a full mouth series. So a lot of dentists are very comfortable having done a full mouth series for many years. But I'm going to come along and say I can take 2 cone beams for less radiation than 1 full mouth series. So I don't hesitate to take a second cone beam in a reasonable period of time, because I know I've still not exposed the patient to as much radiation as an average dentist does taking a full mouth series of bite one, or a full mouth series of periapicals. So I don't have any hesitation to do a second cone beam. And when I did, and I saw the increase in the size of the lesion, then I simply pulled up both images for the patient to see, and I said, Betty, here you've got a small lesion, and now in 1 year and 4 months, it's grown quite a bit bigger and very aggressively. Same thing looking at it from the side view. That stimulated the patient to proceeding with treatment. Now, whether that treatment, in your opinion, should be an apicoectomy, a redo of the endo, or an extraction with implant therapy, possibly a bridge, all of that is up for discussion, and anyone can be correct in whatever the treatment is arrived at. But in my world, I find these things all the time where patients are not aware of them until I point them out. Occasionally, the patient will come back in and verify what we said over time, because they'll start having symptoms. If the patient can see their condition, they'll be more inclined to participate in their treatment. So when you ask about cost of a cone beam, a lot of dentists will say, well, what's the return on investment? If I spend $100,000 for a cone beam and I charge $250 to take a cone beam, well, $250, if I do 4, that's $1,000. So if I do 400, then I might pay for the cone beam. That's not the correct thinking. If I take a cone beam on a patient that I would have taken a Panorex, a PA, or a series of PAs on, I will get more information, more accurate information, and therefore I will do more dentistry. If I do more dentistry than I would have done, that is where a cone beam shines. That's how I get a return on investment for a cone beam. So I mustn't be shy about taking them. In fact, my office, if you come in for a new patient exam, you get a cone beam. If you come in for an emergency exam, you get a cone beam. And if you come in for second opinion, you get a cone beam. So at any point, I'm not shy about taking them. However, I don't charge a lot for them. I charge the same as I would if you were having a Panorex done. If you have insurance and your Panorex was taken 6 months ago and your insurance won't pay for another one, then I take them for free. Because the information I gain is what's going to create the dentistry that will pay for the machine in the long run. So here's a good example. This gentleman hates going to the dentist. Notice he's got root canals and crowns and fillings, and he hates going to the dentist. What I find is human behavior, but what I find is kind of funny. The people that hate going to the dentist the most are usually the ones that take the least care of their teeth. So Mark comes in for a routine hygiene visit. We clean his teeth, we look at the teeth, and I said, Mark, you got a couple of things wrong. And he goes, no, I don't. Everything feels fine. And I said, well, let me show you the evidence. Tooth number 29 has got an endodontic lesion. That means your nerve has died, your bone is going away as the infection builds. And a root canal would be a good treatment for this tooth. So 29, abscess, treatment of choice, endo. The options to that would be to extract it, do an implant, a bridge, something like that, or to just extract it and leave the space. Tooth number 14, Mark, you've got an abscess. And as that tooth has already had a root canal. So now we have a reinfection, failing endo, and the treatment of choice in this case for some people might be a retreatment or an apicoectomy. In his case, we talked about doing an extraction and replacement, possibly with an implant. Now, Mark, who doesn't want to do any dentistry, is now actively engaged in looking at his situation. And I said, Mark, I hate to tell you this, but we're not done. So now we looked at tooth number 2. 2's also had a previously done endo. Looks like it was done reasonably well. And now we have an abscess at the apex and a loss of bone on the buccal. And the abscess goes up into the sinus. And the abscess is more to the buccal and the distal than the mesial or the lingual. You see, I can see all the details of this. And so again, failing endo, that's the diagnosis, abscess. And the treatment of choice in this case also is to remove the tooth. Whether we replace it or not, that's something Mark will decide later. Mark, I wish I could say we were done, but we've got one more thing going on. So we look at number 19 together, and number 19 now has a very small area. And a lot of doctors, they kind of look at this and they say, you know, that's scar tissue. That's from a previous lesion, but it's not there now. And Mark's not having any symptoms. So sometimes it's hard to know whether this is actually a problem or not. But I look over at the coronal view or the cross-sectional view, and I see bone loss on the facial of the tooth. I have an abscess down here. I have bone loss out here. This tooth is mobile and it's going to go away. So Mark, you're going to have to treat 4 teeth. Whether you want to or not, or whether you think you should or not is up to you. But the correct diagnosis is 4 abscess teeth. The treatment plan will involve at least trying to save one of them and trying to replace the other 3 after they're removed. And that's what we discussed. So this is now a second opinion. This patient comes in, tooth number 11. She was just in at her other dentist about 6 months ago. And she's having some symptoms with this tooth. And the dentist said, well, it looks a little bit strange on the radiograph, but I don't see enough evidence to do anything. We're going to leave it alone. So we took the cone beam, the 3D, and on the 3D view, we see a lot more extensive internal root resorption. The patient was educated. We looked at this from several views. The mottled, moth-eaten look inside the root, and then look at what's happening to the outside. So we're losing tooth structure from the internal and external parts of the tooth, and we don't feel like an endodontic procedure is going to solve the issue or preserve the tooth in the long run. So this patient elected to do an implant because she could see clearly from different views the amount of destruction within the tooth. Now, I can't explain why it happens because internal root resorption is a difficult thing to explain, but it has happened, and we see this frequently on our cone beams. Probably once or twice a week, we'll see a case with internal and external root resorption. This is an interesting article I came across, written November of 2019. And it says, because 1,300 and later 500 scans were not read at Walter Reed. Now let me explain what that means. They took 1,300 scans in a period of time. Later, they did a second study where they looked at a different 500 scans that were taken and were never read. So these doctors were told to go take a CBCT, and yet they were never read. The net is, as a result, patients received subpar care. They underwent unnecessary biopsies. Now think about that. We thought we saw something, so we did a biopsy and there was nothing there. CBCT scans, which provide more details than conventional dental x-rays, allow clinicians to better locate tumors, infections, and other conditions. These are the kinds of things that are going to sway dentistry and bring us more into the modern world and looking at things 3D. But I found this very interesting as recently as November. I also find it interesting that someone would take a scan and not read it. Now, would I take a scan on a child? The answer is yes. First of all, remember that number 76 microsieverts on an adult? I can do a child rapid scan at a cost of 26 microsieverts, which means I'm now under 4 bite wings. So 3 PAs or 4 bite wings give me nowhere near the amount of information that this film does. I have an 8-year-old child, and I'm going to look at caries, which I can see readily. I'm going to look at any abscessed teeth, which again, readily evident. Well, what is the tooth position of the unerupted teeth? Look at the rotation on that cuspid in the upper right. And that rotation says we may have an orthodontic consult necessary here. And at 8 years of age, I believe in early treatment for children where we can affect growth and development and not have to extract permanent teeth. So the younger we diagnose, the younger we can treatment plan, the younger we can get started in treatment and encourage growth and development of arches versus extraction therapy. A lot of doctors very topically are interested right now in airway. So here's the airway and the epiglottis. Now, I don't treat epiglottises. I look at airways and I do some treatment, but I'm going to tell you, airways are very important in children and adults. And it's something that I feel is going to become more medical, dental involved, and I'm not sure which way it'll go, but I think it's a very topical and very good conversation to have. Here's another 9-year-old female this time. She comes in for a second opinion because she has a cavity on K. So her mother brought her in because there's a lack of trust, evidently. They wanted a second opinion. They brought all the x-rays. I offered to take my own, and they said they didn't want to pay for it, so I took it for free. By taking that x-ray, I was able to see that K was abscessed and 18 was congenitally missing. You can see over here number 31, but over here there is no tooth bud for 18. Same patient, I also can look at tooth number 4. Number 4 is palatally positioned. By being palatally positioned, mesially tipped, mesially rotated, this tooth is going to develop and erupt in a position that's not going to help that patient. Could we possibly take this 9-year-old child, send her to an orthodontist, and have an orthodontic consult today so we could perhaps extract a primary tooth and help guide this tooth into position and de-rotate it while we're at it? This is a perfect candidate for it. But if you're taking bite wings and PAs, you're not going to run across these kinds of issues. You're not going to see the extent of the problem. Here we've got a 11-year-old patient. So I'm just kind of locking you up in age. And the 11-year-old has an impacted number 22. Look at the rotation on it. It has not erupted into the arch, and it's not going to erupt into a good pattern. It's going to be rotated to crowd itself and get up and into the pattern. And if this root does not dissolve, it's not going to come up at all. I did 26 years of orthodontics. I will tell you, once the root is fully formed, as this looks like it is, then you're not going to have any eruption force to drive this tooth out of the way. So this is, again, in need of an orthodontic consult and some orthodontic treatment. And I find that out because I took a cone beam, and sometimes it's to look at the problem I'm finding, and sometimes I find things when I'm trying to look over here for a tooth number 29 just for a cavity. So the cone beam is just a complete set of eyes. This was an interesting case. Young child, mother went to a dentist, and the dentist said, "You've got something wrong with this tooth. We need to do a root canal, a crown." Well, we took a look at the tooth, and this is internal root resorption or internal resorption based on the pulp. There's a term for it called a ghost tooth. As we looked at this on this 14-year-old girl, we wouldn't be able to do a very good job of an endo because we have open canals down here. We wouldn't have very much tooth structure to work with. And so an endo, buildup and crown on this tooth would be a great cost. And on a 14-year-old female, what are the chances of that lasting her 50, 60 years? So instead, because we've got all this information, we measured the crown, which is 10.5 millimeters in width. We went to the third molar, which is erupting, and we measured 9.65. So it's only about a millimeter smaller, maybe 9/10. Why not extract this tooth and allow this one to erupt into the position? It's called second molar extraction therapy. Now, I don't normally like that therapy, but I ran this by an orthodontist, referred the patient, and gave the orthodontist my opinion along with a copy of the cone beam. And the orthodontist was excited to do the case. So I feel like you're going to become a better referrer if you have more information, and you can send information like this to your referring doctors, whether it's an orthodontist, endodontist, oral surgeon. It makes no difference. Doing perio, it's you cannot diagnose perio without pocket measurements. But when you look at a cone beam and you see angular bone loss, or you look at what we call the axial view, look at all the areas that this patient has, little dark spaces where there's no bone or a lack of bone around the teeth. And those are the areas where I will particularly go and measure and make sure I get a number and determine how much perio is there and can I treat it. But on the cone beam, I can begin to look at a patient that might have severe periodontal conditions. If I have a periapical lesion, I look at the mesial and distal roots. There's the distal root. There's the mesial. Much more involvement on the distal. If this patient elects to do an extraction and an implant, then before the tooth even comes out, I'm going to be measuring the bone width, 10 millimeters, 8 millimeters, the bone height, 16 millimeters, and I'm going to then determine what size implant and how I place it if I were to do an extraction and implant placement. So now I virtually place the implant. And I come in here and I size, position vertically, mesiodistally, buccal lingually, and I look at it on an axial view. how would I put that implant in and to what degree? Tilt, because the roots are tilted. Would I try to get it into the center of the occlusion and support the occlusal table? So all my decisions are made by virtually placing the implant. So if I'm going to do an implant, well, maybe I would take that tooth out that I just showed you and place an implant. Would I do the same here? I have an infection, but I have a problem because the infection has eroded away the facial plate of bone. So what I do is I go in, and sometimes I even draw for the patient right on the cone beam. Look, Mrs. Smith, you see that orange wall? You don't have that wall. So we would take this tooth out and we would graft that area before we could put an implant in. And I can use this to visualize for the patient, demonstrate, draw, create, if you will, so that they understand completely what I would try to build so I have something to house the implant. I do a lot of surgery. I take out thousands of teeth every year, and I extract every tooth I take out prior to the actual surgery by, again, virtually doing it. Just like I virtually place implants, I do virtual extractions. So let's take an endodontically treated molar that's going to be extracted, and I'm going to begin by cutting the crown off. And when I cut the crown off, I'm then going to grind what I see down until I can see two roots. Now, once I can see two roots, I'm now going to be doing two extractions instead of one. But I would like to develop some space. That root fills the entire chamber. And if you're filling the entire socket, there's no place for the root to move. So I'm going to make a cut approximately, whoops, let's go back, a third to a fourth of the way from the buccal plate. I'm going to take a 557 surgical length burr and make a cut. And I'm going to do this for both roots. And I'm going to make that cut 6, 8, maybe 10 millimeters down, but I'm going to look at the angle on my cone beam to determine if I'm cutting toward the buccal, straight up and down, or toward the lingual. Once I've made that cut on both roots, I now tease that small piece of tooth out, and I have space now to extract the rest of the root. So here's an example of a root that I have cut, and then I've teased out that piece of root, and then I took a physics forceps and pulled this tooth from the lingual toward the buccal, and it elevates it as it pulls, and I have room for the root to maneuver in. I take out 99% of the teeth I take out, I do in this fashion. Pre-planning, measuring, then executing. This is a patient that we're looking at their airway, and we can colorize this as we look at it. Now, understand that airways are fascinating, but this is a moment in time. When we took this cone beam, the patient may have swallowed, may not have swallowed. This size and measurement of the airway may change with time. And yet, I can colorize it and say, hey, red and black are very bad. That means there's no space. Blue and white are very good. This is somewhere in between, but it looks like a pretty good airway to look at. I wouldn't worry about this patient having sleep apnea. I wouldn't worry about them snoring excessively. And not that I'm an airway expert, but I can look at every airway and determine whether it's too small or large enough. You can't be too large, but large enough. So I want you to understand that a lot of us are one-tooth dentists. And if you're a one-tooth dentist, you take a PA, you do a diagnosis, you think you're done. I really think that what we need to do is observe all the oral structures in any given scenario. So you're morally, ethically, and legally responsible to diagnose any and every condition in the oral cavity that you were trained in. Now, if I had an audience sitting here in front of me that was able to ask questions as we went along, one of the questions would be, well, Dr. Julian, am I not going to get into trouble if I miss something on a cone beam? And the answer is no. The trouble is you're missing things on 2D now that you were trained in. And doctors are sued all the time for missing things. If you have better eyes, if you have better abilities to diagnose, better technology, it's going to keep you out of trouble. It's going to make you a better, more competent dentist. So reading a cone beam and looking at cone beams, it's just a matter of getting comfortable with it, doing it 200-300 times. But if you continue to be a one-tooth dentist, you're going to miss so much of what's possible. Now, I know that we're in a really strange time right now. And when we go back to work, the biggest problem or the scariest scenario for a lot of people is going to be seeing volumes of patients. The more people you see, the more chance you have of running across a patient that's got the coronavirus. So I'm seeing fewer patients because I'm being more complete on every patient. I'm doing more dentistry because the patients, reluctant or not, are buying into the dentistry because they see it. So I feel like practicing at a very reasonable level and seeing a very reasonable number of patients is a good thing, especially in today's environment. I know that when I go back to work full time, that we're going to be doing things a little differently as far as gloves and masks and sterilization. We're going to be very conscientious, but I don't want to see 50 people in a day. I'd rather see 5 or 6, maybe 7 or 8. And if I'm doing a cone beam and I'm not taking problem-focused PAs and I'm not limiting my vision, then I'm going to see things to discuss with patients. That takes a little time. I'm going to be doing more dentistry than I've ever done before. And as I've had a cone beam, I've really grown in my practice. So understand it, this particular time right now, it's even more encouraging to have a cone beam than it would have been before, because it will keep me safe, if nothing else. So I'm going to show you a really interesting case. Kind of brings it all together. A 93-year-old man comes in with a closed vertical, loss of posterior teeth. His daughter says that he cannot chew and eat and swallow food hardly at all. He gags and he coughs all the time, and he has to sleep sitting up because he can't breathe at night. So we took a cone beam for dental issues, and look what we found on the airway. Not only was it red, black, it disappeared. This is a moment in time. I mean, he's still breathing, he's still alive. But at a moment in time, that airway closes off rather significantly, and it's very small. So vertical overclosure contributes to a smaller airway. I know this. And we went through a treatment plan. And that gentleman today is in temporaries. And we've got some implants in, and we're going to be restoring his upper and lower arches. And by doing this, we've already increased his vertical dimension, and he's breathing better, he's chewing better, everything's functioning better. So even at 93, the information to do this from the cone beam, the total complete information about his teeth, about the bone structure necessary to place some implants, and about his airway and the relationship that has, all comes from the cone beam. So being a complete dentist is really important to me. A couple more patients, then we're going to try to have some time for questions. Is number 32 is impacted. You all can see that right here on this film. And some of you may say, well, it should come out, and some may, well, it shouldn't come out, we'll leave it alone. But here's an interesting thing I've seen over and over again. A tooth that has no exposure to the oral cavity begins to deteriorate. You don't see it on the sagittal view, which would be your Panorex view. You begin to see it as I move through the jaw. I'm literally walking through from the buccal to the lingual. As I do, you can see the infraalveolar canal disappear. It's gone now. And then I take a look vertically down on the tooth, and there is an opening into the tooth. You can see it here. It looks like the pulp chamber, but it's not. It's an opening into the tooth from the external surface. Is that an invasion, like decay, into the tooth? Or is that internal root resorption or tooth resorption from the pulp chamber outward? You know, I don't know. It doesn't look like caries to me. There's no soft edges. There's no indication of a zone of decalcification. What I know is radiographically, this presents a potential problem for the patient. And whether I want to do it or somebody else wants to do it, the patient may or may not choose to do something about that. They may wait till it hurts. But informing and educating that patient will make them aware of the problem, and they now have the ability to make decisions. And that really cements a relationship between a patient and a doctor. What if you have trauma? And these are typical scenarios that come into our office. This is a gentleman that coached a football team, and one of the kids threw a helmet back at him. The helmet hit the tooth. Now the tooth is pushed lingually. He's in my office. And I remember my training from earlier. The training was, well, take the tooth, position it, put a wire across, let it stabilize. All of that was guesswork. Now I take a cone beam. And on the cone beam, I can look and see that what we have is complete separation from the alveolus and absolutely no bone on the facial. If I look at this from a different view, the lingual view, look at the separation here. So if I were to take this tooth and I were to push it back in and stabilize it, will bone grow back out here on the facial? The answer is no. Interestingly enough, if I look at his airway without even colorizing it, I can see that he's got a fairly small, narrow airway, and he's a big, burly guy. So I might treat his tooth, and again, I might have a conversation at some point during treatment about his snoring habits, about his sleep, and if he's interested in doing any kind of sleep study. So this just leads me into more discussion about more potential treatment. Having a cone beam in your office allows you to screen every patient that may need dental services of any and every kind. I talk to doctors all the time who say, yeah, I've got a service that they come by, and if I schedule the patient ahead of time, then they'll take a cone beam for me. Well, the problem is you're going to schedule 1 or 2 patients a week where you've got 10, 15, 20 going through your office every day. And you're underdiagnosing or missing a diagnosis in majority of those patients. If you get a cone beam in your office, you'll be taking it on every patient. Now, what happens is it will make you more accurate in your diagnosis and treatment planning. And the more accurate you are, the better dentist you become. The better referral doctor you become. If you're referring to an endodontist, an oral surgeon, a periodontist, it doesn't matter who you're referring to. Finally, it will allow you to educate your patient and involve them and their treatment choices. We do a lot of implants, but I don't do it because I sell implants. I do it because I'm allowed to show the patient exactly what the problem is and what the potential solutions are. And when a patient can actually see with clarity a dark space, they understand what infection is, that patient will choose treatment, and they'll always choose the treatment that they want, whether it's the cost that they want or not. In fact, everything I do is cost too much, according to every patient I have. But when a patient looks and says, is that infection? The answer is yes. How do I get rid of it? Well, we remove that, we clean it out. Well, can I get a tooth back? And the answer is yes. I'm basically answering questions and becoming a dental counselor at that point, as opposed to a person trying to sell patients on treatment. This cone beam has made my practice busier, and I've had one for 13 years. and I've gotten busier every year for 13 years. So it doesn't do anything but build and grow a practice. You will do more dentistry having a cone beam than you've ever done. And you'll do it on fewer patients. That's the plus here is I don't have to go out and advertise and market for a lot of new patients, and I don't have to see more patients per day. And finally, my level of expertise will increase, and you'll have more satisfaction and enjoyment in your profession than you've ever had before. When you do things better, it makes you feel better. When your patients look at you because you have a better, you start talking, your language changes. You say, Mrs. Smith, you have an abscess. She says, well, my other dentist didn't tell me that, or my other dentist didn't say anything about that. I know, but here you can see it. And if you can see it, you can decide what to do about it. And all of a sudden, instead of me trying to convince her, I'm simply stating facts. And she can decide to participate or not. But it's really a much better way of doing dentistry. And I really enjoy what I do, and I've been doing this now for over 40 years. So I really think those people who bite the bullet and go get a cone beam, they enjoy dentistry a lot more than those who don't. That's the end of the presentation. So John, can we get to questions?
Yes, Doc. So we have a couple queued up here. So the first two are similar here. What are the most important things, and I know you covered this earlier, what are the most important things I should look for in buying a CBC for my practice? And also, if you could put up the slide with the 5 questions to ask when buying a CBCT.
Okay, let me see if I can find the slide. Because I didn't put everything down to ask.
And while Doc is looking for a slide, if anyone else has any questions, feel free in the Q&A box, type them in there.
All right. What are the most important things I should look for in buying a CBCT? It's a great question. What I really think you should look for is a quality machine. All machines are going to cost in the many thousands of dollars. And I hear doctors all the time say, well, I got one for $2,000 less, or one for, it's like, it doesn't matter, guys. I look for the quality of the image. The second thing I look for is the ease of use of the software. How easy is it to manipulate the image, to locate and diagnostically use that image? I'm doing a webinar in another half hour or so. And what I'm going to do on that webinar is strictly go to my cone beam and use image after image after image with doctors who already own a cone beam. I'm just trying to get them comfortable on how to manipulate and how to get to the part they want to see. So ease of use of that. Now, there are other parts to it. What's the warranty on the machine? How good does the company stand behind it? What kind of maintenance issues will you have? And I've had very few. But knowing that there are maintenance issues, how quickly can you get someone to help and cover and support you? And so I think that those are all very important things. Price comes at the end. When I found the best machine and the company supports it, then price is usually the thing that I just put up with because it's always too much. I see a question, do you bill medical for the CBCT? I'm going to answer that honestly. The answer is no. I've tried billing medical on 3 or 4 different occasions over my career, and I found it to be very difficult, very cumbersome, time-consuming, and without good results. However, I'm hopeful that I've come across now someone that's going to teach me and help us in doing medical billing. Because if we could get medical billing, that would be a big help. So the answer for today is no, but I'm hopeful for the future, and I might have better information a year from now. We'll see. Um, okay, the slide with the 5 questions. John, I've got it. Do I need
Yep.
to share screen again?
Nope, it's still up there, Doc.
You got it?
Yep. Should be there for everyone to take a screenshot of.
Yeah. Some machines, let's go from the bottom to the top. Some machines rotate 180 degrees. Some machines go 360. The 360 is a better machine. It's that simple. It goes around and captures more images. I can get number of slices down to 300. The problem is now there's more space per slice and there's less information. The other problem, 512 is a really good number. When I go to 1024, 2 things happen. One, the image gets a little bit crisper, but my eyes can't really pick up the difference. Yet to get that crisper image, the patient has to stand there for at least 20 to 30 seconds more than they do to get the 512, which means staying very still is difficult. So there's kind of a sweet spot there, and 512 seems to be the sweet spot. Voxels, everybody's got a different take on this. It's like a camera. Up to a certain point, the more voxels or the more pixels make a better picture. But if you have 12 million pixels or you have 16 million, can you tell a difference? So there's a certain point where the number of voxels has to be minimal. And once it passes that minimum, you're going to get a good image. The focal spot is really a technical thing. You'll have to have your rep explain to you, but there is a means of measuring the focal spot, and the smaller it is, the greater the image quality. That's really what you need to know. So I showed you a 0.2 and a 0.5. You saw a little fuzziness in the 0.5. How long does it take to reconstruct an image? How long does it take for the patient to stand there and get an image taken? My machine will do a 512 sliced image in about 9 seconds, which is really good, and it'll reconstruct the image in about a minute. So all of these things are really important for you. I don't have to buy extra computers. I think that's important. I don't have to license anything. So there's a lot of things that I'm not bringing up when you get to talking to a representative that they'll go over with you. Okay, let's go back to the questions.
So the next one we have, Doc, is I have a CBCT. When you speak of taking a scan for every patient, do you position the patient's head just so that you get both arches in one shot, or do you take one shot per arch?
Very good question. You can take different fields of view. So there's a 5x5 field of view that will give you about 3 or 4 teeth. Then there's a full field of view, or a large field of view that will give you the entire head, cranium, and everything. I take an 8x10, which is going to give me both arches and the airway on a majority of patients. And I do that for every patient because I want to screen both arches on every case. The only reason for taking a 5x5 is if you're an endodontist or you're looking at just a root canal. But I really think that the more times you have the greatest amount of information, the better dentist you're going to become. So I take a scan for every patient, and I position the patient so that I can get the entire, both arches, get the entire mouth.
Next question, Doc, is what are your feelings on having every cone beam read by an oral and maxillofacial radiologist?
Well, I understand the question, but it's a question that on its face, it's really, you have to understand what you're asking. We don't have enough oral and maxillofacial radiologists that could keep up with the work if every dentist submitted every scan to be read. So if you can read a 2D image, you can read a 2D image on a cone beam. In other words, every slice is a 2D image. You're just getting more information and more slices to read. So you don't need a maxillofacial radiologist unless you come across something that you don't understand, don't recognize, or cannot explain. We're discovering things all the time about anatomy and about certain pathologies that, yes, I send off and have a maxillofacial radiologist read it. But I take about 1,200 scans a year. I probably send 2 to 3, maybe 5 out in a year's time to be read for things I see that I'm not familiar with. If you have a mentor, someone who can help you, someone who's got more experience, I would send it to them first. If they don't understand what they're seeing, then send it to a maxillofacial radiologist. But it's just ridiculous that we think we can do every scan and have it read for us when really what we're getting back from a maxillofacial radiologist is too much information on things that are not dental. I've got several of these, and I like the thoroughness of them. If I have a question, I like the comfort of having somebody to go to, but I'm a dentist, I should be able to read a radiograph. And so I've learned, and I'm through experience, I can read any cone beam, and so can you. Any dentist out there can do this. Did I get all the questions?
That's it on questions, Doc. I want to thank you, first for your time. Fantastic as always. I do want to just make everyone aware about some upcoming webinars that we have here at Diamond. So Dr. Julian will actually be doing next Thursday, 3 p.m. Eastern, CO2 laser applications in general dentistry and implantology. And then on May 15th, Friday, May 15th, we have Dr. Favaghehi doing combining piezo surgery and CO2 laser technology for advanced clinical applications. Both of those you can register at the below link, diamonddentalsupply.com/education. While you're there, sign up for the newsletter. We have a great newsletter that highlights cases, keeps you informed on where we are, what we're doing, and you can get a free CE each month. So again, I just want to thank everyone for their time. If you do have any questions, if you want to discuss CBCT more, some of the specifics with PreXion, happy to provide you with, answer any questions, provide you with pricing. Here is my email address there. We do have special financing and pricing going on, so feel free to reach out. We do, again, have a 4:30 webinar coming up with Dr. Julian, just about 15-20 minutes or so. In that, he'll be focusing a little bit more on utilizing the software, so you'll get to see him actually work through some cases. So hope you all can join us on that as well. And with that, hope everyone has a great day. We will be sending out probably next week your CE, for the credit for the time here. So look for that next week. Thank you, everyone, and have a great day.